Hello, and welcome to the CCO Medical Specialties Podcast. I'm your host, Jill Frost. Today's episode features a discussion with two dermatology experts, Dr. Daniel C. Butler, Assistant Dean, Student Affairs at the University of Arizona College of Medicine, Tucson, and Dr. Shawn G. Kwatra, Dr. Joseph W. Burnett, Endowed Professor and Chair, Department of Dermatology at the University of Maryland School of Medicine. Listen in as they discuss patient candidacy and treatment advancement strategies for using IL-13 inhibitors to treat those with moderate to severe atopic dermatitis, including a detailed patient case to highlight key take-home points. This episode is part of a larger educational program titled IL-13 Inhibition in Moderate to Severe Atopic Dermatitis, a clinical skills curriculum to support evidence-based treatment decisions. For more information on Drs. Butler and Kwatra, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Now we're going to talk about practical considerations for IL-13 inhibitors, which patients are good candidates, and also treatment advancement strategies. So let's start out with a case. So Emma is a 17-year-old girl who has worsening AD with persistent itching and sleep disruption. She has a 4-year history of atopic dermatitis, notable worsening over the past couple years. Her symptoms are itching, scaling, nighttime scratching. She has used high-potency steroids, phototherapy, and emollients. Also has asthma as well. So on the physical exam, very notable red erythematous, thickened plaques, arms, legs, and neck, also with some areas of hyperpigmentation and no evidence of secondary bacterial infection. So we got a good case. This is a classical case. So I think it's important now that we take a moment to discuss some of the key features that make Emma a suitable candidate for biologic therapy targeting IL-13. So some of the big things that we know here about Emma is she's 17. She has worsening atopic dermatitis and she has itching, but she also has that sleep disruption. And so the sleep disruption is also a key consideration here. When I hear the word sleep disruption, I kind of perk up a little bit, especially if your itching is bothering your sleep. What about you, Dan? Is that one of the things that captures your attention?
100%. It's a red flag immediately. And I think it's a nice proxy way of evaluating quality of life, because a lot of times people have a hard time evaluating how much their skin disease is impacting them. They'll come in, they'll say, I'm really uncomfortable. And then the question comes, do you want to escalate treatment? A lot of thoughts come to mind. And a lot of people think, oh, it's just my skin. Why would I take a medication? It's just my skin. I'm not going to die from this, which is all true. But then when you hear that it's impacting sleep, to me, that shows us how much it's impairing your life, your ability to function. And there's a lot of data behind that. So when I hear that, to me, it says, all right, this means we need some sort of treatment escalation.
Absolutely. And then I think we heard some other key things here. So the persistent itching and then the failure. So we have failure of high potency topical steroids, things like clobetasol and phototherapy, and also daily emollients. So when you fail high-potency topical steroids, even throw in some phototherapy, for me, that's an automatic, right? That is the key consideration. So I want you all thinking about that when you actually have poor control with those first-line standard therapies, that opens the door directly to these biologic treatments. And I think that we still have some providers who go with a systemic immunosuppressant route, which I really think is not the right way to go now that we have very safe therapeutics. That's, again, understanding all of the different things that are affected by our treatments. And a drug like cyclosporin would affect so many different cytokines across immune axes versus IL-13 as the true biomarker of atopic dermatitis. And when you switch topical steroids, oftentimes you're really not picking up much, because if you have itching, we've done some studies and others have as well, showing lesional and normal appearing skin, you still have inflammation. You have inflammation in your blood. So if it's not working, I don't waste a lot of time with those different topical agents. So we're also going to talk a little bit more about the practical nitty-gritty of getting your patients on biologic therapy. So when to advance therapy? Persistent symptoms despite optimized topical therapy. Having that in your notes documented, very important for getting these therapeutic agents approved. That's really the most important thing. Also having flare-ups with itch and sleep disturbances. Sometimes we monitor that with some tools like the itch numeric rating scale score, 0 to 10. What's your worst itch in the last 24 hours? You get a quick sense of where people line up. There's also some tools for the eczema severity, the EASY score, the SCORAD. And then advancing to systemic therapies, the biologics are very tailored, very specific treatment options. You do have other options, systemic, non-specific therapies. There are also JAK inhibitors, which are also pretty fast in terms of their efficacy. And having these patient-centered conversations about fears and expectations of biologics are very important. Actually talking about how this is much more specific therapy targeting one thing, one molecule. That's the number one biomarker in atopic dermatitis. And then talking more about the long-term benefits, excellent, great safety data, and shared decision-making, also some of the trade-offs of not treating appropriately and having continued disease, some of those trade-offs of what that actually means. But it's really important that we actually hear from a live patient about their experience. We can talk about it all the time, but it's great to hear it directly from a patient. So we're going to share that story for you now.
When the option for trying biologic treatment was first proposed to me, at first I was terrified at the idea of being jabbed by a needle, not just one, but two, and pretty frequently really scared me. Next was the cost, the financial burden that would impose on me, being that the drug is, fairly new and quite expensive, and there would be certain financial implications on that. And lastly, the practical part of who's going to administer and how it would be administered, whether I'm at home or on the road, was a challenge, but that was sort of much lower down on the level of considerations into starting a biologic. When considering a new treatment, and this really applies for all treatments, not just a biologic, for me personally, the number one consideration is how safe it is. What are the side effects? Subsequently, cost, because a lot of these medications are very pricey. And convenience, again, is a last consideration, because if the medication is working and it's helping and it's improving my day-to-day quality of life, then the potential slight inconvenience that it might play a role into my day-to-day living, for example, traveling with a biologic, only happens seldomly. So I wouldn't prevent that from being a reason to attempt a new treatment, specifically a biologic.
That's great. So let's touch on some of our key takeaways. So IL-13 drives atopic dermatitis pathology, impairs the skin barrier. So IL-13 leads to decreased filaggrin and loricrin, increases inflammation and itch. Biologic therapies that target IL-13 improve barrier function, reduce inflammation, and also decrease pruritus. And we know that failing the topicals, first-line topical therapy is high-potency topical therapy is one of the main things that allows you to then go to that next step. And also the important patient factors of frequent flares of their itch are very important. When you are on these advanced therapies, you can easily monitor with some simple tools like an itch numeric rating scale tool or the EASY score. And then it's very important to also have patient-centered biologic discussion. So talking about safety concerns like conjunctivitis, injection reactions, and emphasizing also the long-term disease control and reduce steroid use and some of the different problems that we have of steroids. Although many providers, primary care providers, oftentimes give these steroids, they're definitely associated with all sorts of side effects that patients need to be aware of.
Thank you, Drs. Butler and Kwatra. And many thanks to you, our listeners, for joining us. As a reminder to view the full program, IL-13 Inhibition and Moderate to Severe Atopic Dermatitis, a clinical skills curriculum to support evidence-based treatment decisions, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.